Welcome everybody to the Pancare Foundation Understanding PEI and PERT for Health Professionals webinar. We're delighted to see so many people on board this evening, and the interest in this topic has been overwhelming. So we're really excited to present some great questions and content to you this evening. My name is David Menzies. I'm the head of PAN support at the Pancare Foundation. And again, I welcome you all here this evening. I will do the introduction of the panelists. Before I do that, can I please acknowledge country? So can I acknowledge the traditional custodians of the land where I'm situated? I've lived and worked on Wurundjeri land of the Kulin Nation for virtually my whole life. I pay my respects to elders, past, present, and emerging. I pay respect to ancient wisdom of the oldest surviving culture on the planet, and I pay respect to the strong connection our First Nation people have to land, sea, and waterways, and in particular, I pay my respect to any Aboriginal and Torres Strait Islander people that may be in this meeting this evening. So the Pancare Foundation, really quickly for those of you who are unfamiliar with us, are a charitable organisation focused on supporting people with pancreatic and upper GI cancers. So when you get an opportunity, please visit our website and have a look at our services and resources that we provide across the country. So without further ado, I'll introduce our panel, starting with our facilitator for the evening, which is Lauren Atkins. And Lauren is an advanced accrediting practicing dietitian and has been doing that for over 10 years, working in oncology nutrition at the Peter Mac, the Royal Children's Hospital, the Epworth Health, and has co-founded her own business, Encore Nutrition, that allows greater access to specialised cancer nutrition support at all stages of care. So Lauren will be wearing two hats for us this evening, and she'll be delivering, funnily enough, from a caravan in her backyard or in her driveway. Not that you would know with the with
thanks for the background. Yeah. Thanks for pointing that out, David. Much
no worries.
appreciated.
Second, we have Professor John Zalcberg. John's the head of cancer research program in the School of Public Health and Preventative Medicine at Monash University, providing academic leadership to a number of clinical quality registries. He holds the inaugural Tony Charlton Chair in Cancer Research at the Alfred Hospital and Monash University, and he practices as a GI gastro-intestinal medical oncologist. So welcome to you, John.
Thank you.
I'm also delighted to welcome Christine Constantino. Christine is a tireless advocate and voice for people with pancreatic and upper GI cancers. I've had the pleasure of meeting Christine a few times face to face, and not only does she bring joy to any room that she's in, she'll bring joy to our experience here this evening, but she'll also give us a real life experience of what it's like to deal with pancreatic cancer. And I think, Christine, you're coming up on 8 years of survival this year, so will give us some amazing insights. And finally,
hi everyone.
Thank you, Christine. And then finally, I'd like to introduce Associate Professor Mehrdad Nikfarjam. Mehrdad is one of the highest volume hepatobiliary surgeons in Australia, practicing out of the Austin Hospital, Melbourne. Mehrdad is instrumental in leading world-class interventions and research into pancreatic and liver cancer. Dr. Nikfarjam also holds roles as Associate Professor with the University of Melbourne, Department of Surgery, and has over 100 publications in peer-reviewed journals. Mehrdad is eminently qualified to speak on this subject, as he was the lead author of a guideline summary on the diagnosis and management of pancreatic exocrine insufficiency, published in the Medical Journal of Australia in 2017. He also contributed chapters 10 and 11 of the Australian Guidelines for the Management of Pancreatic Insufficiency, published by the Australian Pancreatic Club. So welcome to you, Mehrdad.
Thank you.
I will now hand over to Lauren, who's going to facilitate the questions through the panel. If you can, please stick your questions in the Q&A, and we'll have a questions section later on. We don't expect we'll get to everybody's questions, so we promise that we will, when the session's complete and you're provided with the recording, we will also be providing a written response to all the questions that we don't get to this evening. So thank you, Lauren, and over to you.
Thank you, and thank you for your wonderful introductions, David. It's a pleasure to be here, and yes, coming to you from not my caravan, sadly, but my parents' caravan in their driveway. Nowhere exciting, but it's really quiet in here. So good reason to peel myself away from the family and the chaos everywhere else. And it's a pleasure to be spending our Wednesday evening with you all. So I'm going to direct our first question to you, Professor Zalcberg. Could you tell us a little bit about pancreatic exocrine insufficiency and pancreatic enzyme replacement therapy?
Sure. Well, I think probably the easiest way to, and I should say that I'm really privileged to be here as well, and also to be amongst this panel of real experts. So, and I'm a medical oncologist, and many of the people that I see that Mehrdad and other people have operated on are have already had enzyme replacement therapy. But I think the way that I think about this really conceptually is that what the function of the pancreas is. So it's a critical organ that produces a variety of hormones. So hormones like insulin, for example, which is a really important hormone that regulates blood glucose. And if you don't have a pancreas that's functioning, either it's been damaged or taken out surgically, then insulin, of course, is one of the hormones that you would lose as a result of that. So it's an important hormone that we all know about, and people who don't make enough insulin become diabetic and need insulin replacement therapy. So that's one of the hormones that the pancreas makes, but it also makes a number of enzymes which are critical in digesting food. So we eat food and we enjoy food, hopefully as much as we can. And food contains a lot of constituents, and it's quite a complex mix of things. When you think about it, break it down, it becomes much less enjoyable than sort of going to a restaurant and eating off the menu. But now you've got proteins and fats and sugars and carbohydrates, and all of those things need to be metabolized or broken down to their constituent parts so that they can give the body essential nutrients, help in maintaining body weight, provide proteins that are critical to cellular function, and so on. So when those enzymes are not only in the pancreas, but are included in the pancreas. So when the pancreas is not working properly, then those proteins and fats in particular can't be broken down, and that leads to gastrointestinal symptoms. And so enzyme insufficiency is essentially just what it sounds like. It's not enough enzymes produced by the pancreas, either because the pancreas is not working properly or because the pancreas has been damaged or removed. So not enough enzymes to digest those food products. And enzyme replacement therapy is the use of commercial products that provide an external source of those enzymes to help in that digestive process. Sorry, very long-winded answer, Lauren, but
no, very, very thorough, very, very clear. So, in a nutshell, the insufficiency, as you would imagine, is when there's not enough enzyme, and the replacement therapy is to counteract that or to make up for that insufficiency.
The missing enzymes, correct?
Yeah. And so, what are some of the signs of pancreatic exocrine insufficiency?
So, and I talked about insulin, and Lauren just used the word exocrine. So just to distinguish, so insulin is an endocrine function. So it releases a hormone into the bloodstream, which regulates blood glucose. And exocrine is the function of the pancreas producing enzymes that just help in digestion of food. And one of the things that I guess commonly experienced by patients is just non-specific gastrointestinal symptoms. It might be just indigestion or discomfort. It might be gas and burping, but also it might be fat malabsorption where the fat's not absorbed, not dissolved properly, and then that fat leads to discomfort in people using their bowels with either in terms of the quality of the stool, the gas, and so forth. So there are a range of things that can interfere with the digestion of food, lead to a range of symptoms in the GI tract. I guess maybe, Lauren, you probably see more of these symptoms on a regular basis than what I do, but in terms of understanding the detail here. But I don't think of any one symptom as being predominant. I just feel like different people experience this in different ways. But clearly people are aware that there's a problem.
Yeah, and that's so interesting that you say that, because I think as health professionals, particularly through training at universities, we're taught to look out for, in particular, fat malabsorption, and that's steatorrhea, where you might see pale or floating or foul-smelling stools. But that's just one sign. And if you do have someone present with generalized discomfort, cramping, bloating, abdominal pain, but that they may not have really distinct fat malabsorption symptoms, it shouldn't be excluded that they may not be PEI still happening.
Yep.
Yeah, really good point. And what would some of the medical or nutritional consequences of that exocrine insufficiency be?
So, clearly some of the vitamins that our body needs, vitamin D, vitamin A, and so on, are what we call fat-soluble vitamins and require fat to be metabolized properly in order to be able to absorb those vitamins. So that's certainly one of the things that can occur if there's fat malabsorption. I think probably defer to you and to Mehrdad around this in terms of other sort of consequences, but it's important that people maintain adequate nutrition and especially after major surgery, and if they're unable to absorb these essential nutrients. So fats are essential to our body and proteins are essential to our body function. And if we're unable to absorb them properly because absorption requires them to be metabolized, then there may be, weight loss, there may be just malnutrition may occur, apart from the inability to absorb some of those fat-soluble vitamins important in things like bone health.
Yeah, and I often refer to the role of the enzymes as a saw or a cleaver. And what I like to imagine is that the nutrients, the fats, the proteins, the carbohydrates are like a chain or a necklace. But in order for our body to absorb them, we need to break those down into those links of the chain. And that's what the enzyme does, breaks them down. And in someone who doesn't have enough enzyme, they're essentially eating a necklace or a chain. If they can't break it down into single links, then that ends up going straight through them and ends up coming out the other end in the toilet bowl, which not only is a wasted effort of eating when someone's probably not got a great appetite to begin with, but it also means that they're not absorbing those valuable nutrients and that the calories, the energy that comes from that food. So absolutely agree. Malnutrition is really common in that scenario, not just through protein and energy malnutrition, so not absorbing enough energy and as a result losing weight and losing muscle mass, but also micronutrient malnutrition, so insufficient absorption of vitamins and minerals. And those fat-soluble vitamins, vitamin A, D, E, and K, are the ones that we need to be really mindful of when fat malabsorption is at play. And of course, that can then translate to weight loss, to muscle loss, to lack of energy, just feeling so tired and
fatigue, exactly right.
And just a general malaise and lackluster, which many people would consider standard as after surgery or after chemo, but it certainly can be managed, and pancreatic enzyme replacement therapy can make a huge difference to someone's energy levels, which is really important to keep in mind. Wonderful, thank you. And I'm going to direct this next one to you, Associate Professor Nikfarjam. How and when would your patients with pancreatic cancer use PERT, use pancreatic enzyme replacement therapy? And does that change at different times of their treatment?
Yes, based on recommendations, all patients with inoperable pancreatic cancer should be offered pancreatic enzyme replacement therapy. Not all of these patients will have pancreatic exocrine insufficiency. So, for example, a patient with a small cancer in the tail of the pancreas may have enough viable pancreas to make enough enzymes. But one of the things to consider for pancreatic cancer, there is a high association of pancreatic cancer with chronic pancreatitis. So even though the tumor may be located in an area where it's not blocking off the digestive juices from the most of the pancreas, there may be an element of pancreatic exocrine insufficiency. And so all the patients with the inoperable, the recommendation is provided for them. I think patients with pancreatic cancer have got enough to deal with. There's the issues with weight loss. There is also the issues with malabsorption. You just want to maximize their outcomes. So you want to exclude malabsorption as being a possible cause of weight loss. Okay. And you can do that by prescribing the enzymes. All the patients that I operate on with pancreatic head tumors, for example, I do put them on pancreatic enzymes routinely. Not every patient will require it. Sometimes you will operate on a pancreatic tumor where the remnant pancreas looks completely normal and would produce enough juices. But when a lot of these patients are having chemotherapy, which is associated with weight loss, you just want to exclude malabsorption as a possible cause of the weight loss. So I tend to put all my patients who've had a pancreatic duodenectomy or Whipples operation on the enzymes at least during their chemotherapy. Once they finish, which is approximately 6 months after, these are people with operable cancers, then I may individually look at whether we try reducing the doses of the enzymes or look at stopping altogether and seeing if they're getting any symptoms of indigestion or other associated problems. So it's a routine thing, but definitely inoperable, all of them. Patients having a pancreatic duodenectomy for pancreatic cancer, all of them at least during their chemo. And then other patients having a surgery where distal pancreas, where the pancreas looks completely normal in other aspects, I may not put them on enzymes.
Okay, and it's sounding like you kind of err towards putting your patients on Creon and pulling back if it appears unnecessary rather than the other way around.
That's how I do it. But one of the things also to consider, you may look at doing fecal elastase testing, and that's not always a good indicator. So when you have a Whipples procedure, you essentially change the plumbing within the abdominal cavity. And sometimes the pancreas juices will not mix with the food in a coordinated manner. So these patients might have enough juices in the gastrointestinal tract, but it might not be mixing with the food as it used to do because of the change in plumbing. So you could, if you don't give enzymes to those patients, there still would be an element of malabsorption. So I think you're completely right. It's better to err on the side of caution.
Yeah, especially like you said, there's a lot going on and there's lots of balls in the air. You want to rule out any exocrine insufficiency. And
Lauren, can I ask Mehrdad a question? Is that
absolutely?
Okay?
Please do.
Mehrdad, what's your view around when you should start? So if someone's had a Whipples, day one, would you, by the time they go home, say a week later, would you think they should be on an enzyme replacement at that time, or would you think by the post-operative visit at 6 weeks? When would you start?
So a lot of these patients will have a mild delayed gastric emptying. So it depends if they're tolerating soft diet. Often a lot of my patients early on, I'll put them on a puree diet and then tell them you can, start cheating. But I kind of don't push for them to resume a normal diet very quickly. And I tell them if you're tolerating a puree diet, you might look at, if you're on a 25,000 unit dosage, you might look at 1 or 2 tablets with that main meal. So I start them usually in the hospital when they're starting at least the puree diets, and hoping that at least on a soft diet they'll be on it. I don't push for their snacks as much early on, because often they're not eating that much of a fatty snacks, may not be eating too much fatty snacks early on. So I just insist that to begin with, at least with the main meals, and consider having a tablet of 10 to 25,000 units with a snack, at least if it's a fatty snack. If they're having a little bit of an apple or a bit of fruits, you don't really need it in those circumstances.
Okay, thank you.
And my understanding is too that the pancreatic enzyme exocrine insufficiency can present many months later once that that remaining exocrine function kind of wears out. Is that correct?
Look, I think it can present later on as well. So it's something to be aware of. One of the things that I kind of think from a general practitioner is to be important, especially if you're actually looking after patients with chronic pancreatitis who are on pancreatic enzyme supplements, and all of a sudden things worsen in terms of malabsorption and they seem to be having their symptoms worsen. That's an alarm valve for me that you've got to maybe re-image. They might have developed a pancreatic cancer. So patients with chronic pancreatitis, high risk of developing pancreatic cancer. And also looking at your patients that you're doing the Whipples operations, if their symptoms all of a sudden worsen, consider that something else may have happened. And you do get people with recurrent cancers. And now you've got a lot more long-term survivors who I've seen in a few patients develop a second pancreas cancer in their remnant pancreas 3 years or 4 years down the line. So pancreatic cancer itself is a major risk factor for developing pancreatic cancer, because that pancreas is somewhat damaged for some reasons unknown. So I think if you see those in general practice, for some reason patients who've got pancreatic exocrine insufficiency, their symptoms worsen, consider that. And it sometimes pancreatic exocrine insufficiency in a small number of cases is the presenting symptom for pancreatic cancer. So patients come in with unexplained diarrhea. They've got all the symptoms of pancreatic exocrine insufficiency. They end up having a gastroscopy, a colonoscopy, stool cultures, and then it clicks to someone, hang on, we should maybe do a scan to see what's going on, and a pancreatic cancer is discovered. So unexplained diarrhea that's persistent where you don't have an obvious cause, think about that could be pancreatic exocrine insufficiency, and it could be an indicator of pancreatic cancer.
Great advice. And look, we're not covering too much here, diagnostic tools, lab tests. So if there are any particular questions about that, we'll save those for the panel at the end. But I'm going to open this up to either of you now. Really keen to understand how you would perform a clinical assessment to actually understand who requires pancreatic enzyme replacement therapies if it's not clear from their particular diagnosis or surgery.
I guess if you're dealing with people with the cancers, pancreatic cancer, I think as we talked about, you err on the side of caution. You just, if it's inoperable, you know the pancreas, if it's a pancreatic head tumor, you know that the pancreatic duct is blocked, and these patients are going to benefit from it. As you mentioned, Lauren, you know, there are micronutrient deficiencies. Some of these may affect the immune function, and you want to have the 1%ers in your favor when you're tackling cancer. You want everything to go your way, and I would err on the side of caution and just treat them all. But you do get patients with the classic symptoms, excessive bloating, loose stools, floating stools. You hopefully don't want to be, you want to be kind of avoiding that rather than watching for that to trigger you to treats.
Yeah, I was going to say the same really as Mehrdad. I see it as being mainly an empirical, you know, as Mehrdad said, he's sort of almost doing it routinely now on just by the time people are eating. And look, there are some people who don't like taking replacement therapy or don't need it. That's true. But rather than do a whole lot of tests to try and sort out what's going on. At least it's relatively simple. It's covered by the PBS. It's not a major expense or from the majority of people, and it can lead to quite substantial benefits. So, you know, the people who don't have these conditions take eating and enjoying food for granted, and patients that have been through this surgery and have these sort of problems are really, it's a struggle. And, you know, sometimes I say to people, you know, when you have a medicine that doctor gives you and you don't like it, what do you do? And the answer is you take it, right? So I say sometimes you've got to treat food that way. And that's really, but it's sad in a way, isn't it, really? Because as I say, if you're not sick, you take eating food and enjoying food, not just eating, but enjoying it for granted. And so I think this is a way of trying to restore that sort of enjoyment of not getting the discomfort that comes with it. There's nothing worse than thinking I'm going to eat now, and as soon as I eat more than a couple of mouthfuls, I'm going to have bloating, I'm going to be burping, I'm going to pass wind, you know, all sorts of things that people just stop eating. And guess what happens? They lose weight, they lose muscle condition, they get fatigued. It becomes a vicious circle. So I think it's really important, as Mehrdad has said, to really optimize it, you know, err on the side of caution, let people receive these, you know, they've had damage to the pancreas. There's a reasonable chance, if not a high chance, that they have insufficient pancreatic function. And as much as we can, we need to try and provide the opportunity to address that.
Yeah, absolutely agree. And certainly in practice, I see those who commence Creon can absolutely change their world, their appreciation, enjoyment for food, their energy levels, just their quality of life can be significantly enhanced. So great advice. And in terms of, you touched a little bit on dosing before, Mehrdad. I often see patients come through to me who are given a blanket dose, kind of told to take it around about your meal time. Could you give any advice on dosing and timing of Creon or pancreatic enzyme replacement therapy?
Sure. I guess it is an individual tailoring it to some extent. Generally, for the average weighted patient, I usually provide between 25 and 50,000 units per meal. Usually I start off with 50,000 units. So the recommendation is on average around 40,000, but the tablets we have, the tablets available for us is 10,000, 25,000, and now 35,000. It used to be 40,000 units. This is, we're talking about the more generic, the more commonly used enzyme, which is Creon. There are different types, but the most commonly used is Creon. So I usually say I start off with 25,000 unit tablets, 2 with the main meal 3 times a day. I always say, you know, take a mouthful and start having the tablet. You do get patients who have, for some reason, they've been told to take it before their meal for half an hour or so, and by then a lot of the enzymes may have gone through them. So you want the enzymes to be mixing with the food. If the patients have real issues with pancreatic exocrine insufficiency, I try to space it out. So they might have 1 tablet with the start of the meal, and later on through a larger meal have another tablet as well. And, you know, there are times you might go for 3 tablets. So I start off with 2 with the main meals and then a 1 with the snack. I tend to go for the 25,000 units, but I guess for the snack, probably 10,000 units is sufficient, but it means, you know, having 2 sets of tablets as well. But I don't think it does much harm having slightly more. So that's my general start off.
Really good advice. It's nice to have that starting point.
Lauren, they asked a question. What happens from the panel members about where you can't swallow it? What's your advice when you can't swallow the tablets? What do you tell the patients? So
in order for the enzyme to actually make it through the stomach and into the duodenum without being damaged, because the gastric acid can actually denature the enzymes, the protein in the pancreatic enzyme replacement therapy. What I normally encourage people to do is actually open the capsule and put it into something that's acidic. So generally something like an apple sauce would be a good vehicle for it, and swallow that down. Easier to swallow than the actual capsule. And that applesauce helps to protect the enzymes from the gastric juice so that it can reach the duodenum, the intestines, where it can then function as it's intended to break down the food.
Okay. And I guess on your other point is some patients, a lot of patients are on proton pump inhibitors, so antacids, and theoretically that does improve the effectiveness of the enzymes by reducing the acid in the stomach. So when they're on proton pump inhibitors, that could improve the effectiveness, although some of the proton inhibitors do have a side effect of diarrhea as well. So you have to be, not all the medications, some medications will have side effects of their own.
For sure. I normally, a rule of thumb when it comes to timing, certainly first mouthful, first creon is my advice as well, but I generally recommend the knowledge that it may only last about 20 minutes in the system. And so if you're going out for a long lazy lunch or you're feeling like dinner's dragging, every 20 minutes you'll need to replenish that creon supply in order to keep your food being digested. And to your point as well, as dietitians, one aspect of our care is to provide really prescriptive creon dosing to their food and nutrient intake. So there's an equation that we can equate creon dosing or PERT dosing to particularly grams of fat, but also protein that's in food, to make sure that for particular meals that may be really high in protein and fat, you're actually getting enough creon to digest and absorb that meal effectively. So always a good idea to get that tailored advice to make sure that your meals are being appropriately absorbed.
But sorry, one of the problems I see, sometimes patients get this misconception that they should be avoiding fats. And I think fats are important from an energy point of view and the recovery. So that's why seeing a dietitian, looking at a tailored management is important, because you don't want patients to avoid fats. You want to have creon and have the certain fatty foods with a lot of nutrients that will help with recovery and weight gain.
Absolutely. And I so often see patients quite intuitively actually reducing their fat intake, cutting it out, because it makes them feel better when they're not using their creon properly. But what we actually need to do is reverse that and say, please liberalize and eat as much fat as you feel comfortable and able. It's important, vital nutrient for many functions in the body, but take enough creon to absorb it. So really good point there.
And the other thing, Lauren, that I've observed, I guess, over years is that people have a view around certain diets or perhaps a Western diet causing cancer. And so thinking that now's the time to go on a healthy diet. But as Mehrdad has said, and you said, this is a period of people in great stress. You know, the cancer, the surgery, the chemotherapy, they cause great stress to the body. And it's critical that we provide the nutrients that are required. And so you're absolutely right, we shouldn't be avoiding it. But at the same time, if it's not tolerable, people will naturally avoid it. So that's why the replacement is so important. There's a question I noticed about religious things, religious reasons. And I know you want to come to questions, but maybe I just wanted to comment around that briefly, because I think as most people will aware, at least most of the, at least the common version of pancreatic replacement therapy that Mehrdad mentioned, creon, is derived from pork pancreas, essentially. And so I guess it is a complicated question, I think, as to what to do about it if you are either allergic. Well, if you're allergic to pork products, that's one issue. But the other part of this is not a question of allergy, but what do you do on religious grounds? And I think people just that needs to be discussed, because I don't know, maybe you do, Lauren or Mehrdad, if there are other forms of enzyme replacement that are not derived from pork. It'd be great if there were, but if there aren't, then it becomes a question of if I always think if you can look after your health, then surely that's got to be the first priority of a religious principle, is to look after yourself so you can help others and be with family. But I guess people will have to make their own decisions about that. I don't know that there's any solution. If you say I won't take it for reasons like that, I'm not sure there's any solution. Lauren, is there any?
So in terms of alternatives, my understanding is that all pancreatic enzyme replacement therapy available in Australia is pork derived. So it is really, really challenging for those who are quite adamant that they either want to avoid it for cultural, religious reasons or have to avoid it, need to avoid it for porcine allergy reasons. I've had a number of clients, particularly with pork allergies, where we actually haven't been able to safely administer Creon. And as a result, we had to move on to what's called an elemental diet, which is essentially provision of a nutritional formula that is already broken down into those small units. So already providing the links rather than the chain in food. A particularly unpalatable formula that's usually given enterally through a feeding tube. For this particular patient, he could drink it, didn't enjoy it, but it was a way to sustain his nutritional needs. So I don't know, Mehrdad, if you have any other alternatives there, but I haven't come across any alternatives to the pork.
Look, I haven't come across either. I know there are some brands on the shelves that patients obtain, and that's claimed that they replace the function of the Creon or the other porcine-based enzymes, but I don't know if it's proven. So that is a problem.
Yeah, it's a real challenge and very well pointed out. John, thank you for bringing that question to the line.
Most of the religious leaders that are there that patients have don't want to take it from religious grounds. If they talk to their religious leader, that exemptions are given. It's like they kind of accept that that's the case. It's like football players who are Muslim in background being able to eat during the holy month of Ramadan. They're given exemptions because of health reasons and stuff. So I think it should be discussed with the religious lead if that's a concern.
I agree.
Yeah. And you mentioned earlier around preferring to give too much Creon rather than not enough. Perhaps, Dr. Zalcberg, do you have any insight into side effects of Creon, whether it's having too much or just having Creon at all? Are there any particular side effects that you've come across that might be worth noting?
So I haven't come across them myself. I know people talk about sugar management of glucose, high and low sugars maybe is a complication. I've seen that reported, but I haven't. I think probably the one I've come across most of people complaining about, and my experience is not anywhere near as extensive as yours or Mehrdad, is just feeling that it changes the palatability of how that sort of issue. But I don't think of it as I think there's so much that the what we call the therapeutic ratio, the benefit over the side effects, or is so large in favor of it that I don't see it as a treatment. I give chemotherapy for a living, right? So compared to chemotherapy, this doesn't have side effects.
Very good point. Very good point, and certainly better than the alternative if you're malabsorbing.
Yeah.
I guess it's worth pointing out too that there is a small amount of research, mostly in actually the cystic fibrosis population, on maximum doses of pancreatic enzyme replacement therapy. Certainly happy to share those numbers, those figures with the audience. It's related to units of enzyme per kilogram of body weight, particularly looking at the lipase component. But Mehrdad, do you have any concerns around maximum dosing or any other points in there?
As you mentioned, Lauren, the dosages, the side effects, there's literature based on the cystic fibrosis. If you have too much, it causes a condition of a fibrosing colitis. It can affect the colon lining, but it's not really something that's been shown in non-cystic fibrosis type setting. Certainly some patients complain. They say that when we have Creon, I get abdominal pains, or I get constipation, or it causes diarrhea. All these these symptoms that you wouldn't expect, and some of them are convinced it's related to the prion, but I think side effects by and large should be very, very rare, and a lot of these complaints are probably related to the cancer itself rather than the prion.
Yeah, I tend to agree. And just for context, even in that, the theoretical concern around the CF population, you need to be taking more than 24 capsules per day, which is a massive dose. I've not seen a single patient taking that many. If they were, I'd actually be concerned about what else is going on that's requiring them to have such a massive dose of replacement therapy. So thank you both. I am really, really pleased, and we're so fortunate to have Christine here on the panel, and I'm sorry to have kept you silent for so long over there. And my understanding is that you've had not only first-hand experience with pancreatic cancer, but also with pancreatic enzyme replacement therapy. So I'm really keen to get some insights from you on your experience, Christine, and what us clinicians should be aware of when we're recommending and prescribing pancreatic enzyme replacement therapy.
Well, I think, I mean, it's been a godsend for me, but I was fortunate enough to be referred to a dietitian. It was as though, it doesn't seem as though GPs know a lot about prion at all, like they don't seem to know enough about it. But my experience is that dietitians do, and when I was referred to a dietitian, she was able to tell me about the different dosages and about how to take it in the same way that you were discussing it. You take a mouthful of food, you take the prion with it, and then it lasts about half an hour. So if you're having a long lunch or whatever you're doing, you take another one later on. And also, I mean, I think because I've been on them for so long now, I've kind of worked out whether I need to take 10,000 or 25,000 or 25,000. I mean, if I'm having a nice creamy pasta that's full of fat, I mean, I might take 25,000 tablets instead of one. So yeah, it's kind of swings and roundabouts, and I think it's about balancing and knowing your own body, as well as taking the advice of the experts and working it all out. So it's not, there's no simple answer, I don't think. I don't think that there's just one answer for everybody.
But that's perfect, because what you've just described is that you took the time to seek that education and gather that information so that you had the tools to actually make those adaptations and changes to your dosing, not just to suit you, but to suit each meal and snack that you took on. So, you know, you're not having to ask every time, all right, I'm having fish and chips for dinner, how many prion should I have? You had the knowledge to make those adjustments yourself. Yeah. So that's fantastic.
How many potato cakes, yeah.
Exactly.
So, yeah. I'm sorry, I'm in my jammies, but I'm sorry.
I'm in the caravan, don't worry.
I never thought I'd hear a dietitian talk about the fish and chips for dinner, but...
we mustn't have had a chat for a while, John. I think, no, it's wonderful to hear your insights there. You mentioned it's a godsend. What did you notice in particular when you started Creon? What changed for you?
I wasn't having... I mean, I was having diarrhea, like, and you put it, bright yellow, bright orange, just really uncomfortable all the time, you know, not able to, I mean, all the sorts of things that we've been talking about today of not wanting to eat because it was making me feel, and sorry, they're brats, those children.
Love it.
Yeah, but that whole thing of not enjoying food or thinking, oh, if I eat this, what's going to happen? And because I love my food, and it was really good, you know, to sit down and have a cream cake or have whatever I want to eat, but you know, be able to do it in a way that wasn't going to make me feel sick or bloating, or, you know, have gas or whatever. It was just. It really was a godsend, and it made me feel so much stronger, because when you've got diarrhea all the time and you feel sick all the time, it just drags you down. The mood as well, you know, it drags your mood down if you can't enjoy your food. So important.
Certainly, your mood, not only physically, how you're physically feeling, but psychologically, socially, every birthday cake, you know, you'd be questioning whether or not you're going to have some. So I'm delighted to hear that Creon's really made a difference to your life, Christine. That's fantastic.
Yeah, it's a huge difference. And anyone that's not on it and isn't feeling well or whatever should really talk to their doctors about whether they need to be on it.
Yeah, that's great. And look, we're coming towards the time where we might switch to questions, but I might just put it back to you, Professor Zalcberg, Associate Professor Nikfarjam. Any closing comments, statements, words of wisdom that you'd like to share with the audience before we jump over to questions? Let's start with you.
John, do you want to go first, John? You're on mute. Look, you can go, John.
Well, look, the only thing I was going to say is I think we're running a pancreatic cancer outcome registry here where I work at Monash, and we're trying to measure quality of care for people diagnosed with pancreatic cancer. And one of the things that we weren't measuring really, mainly because it's not easy to capture the data, is how often creon's actually used. So, and this is very early data that we've just done one small pilot project just to start this idea of saying, well, let's find out if it's being used routinely. And so we looked at one hospital, just not where Mehrdad is, I might say, but one substantial hospital in Melbourne. And at the time of discharge from hospital, less than a quarter of patients were on creon at the time of discharge. So that's a bit, sort of why it was a bit of a, not so much a Dorothy Dixer. I hadn't told my dad that I was going to ask him, but I did want to get a sense of what's the right time to start. But by the time people get to their 6 weeks appointment, these are all people who've had surgery for pancreatic cancer. By the time they're coming for a 6-week post-op appointment, it looks like about half are on creon. So now there may be reasons, you know, the problem with real world data, as we call it, is that there may be good reasons, you know, people have tried it and don't want to be on it, or they're getting it from their GP and they don't get it from their surgeon. So we you know, obviously it's early days, but we do have a sense that, and some research done out of Queensland also suggested that enzyme replacement therapy wasn't used as often as maybe it should be. So I think this sort of webinar is really important because it helps inform the community about the importance of these type of efforts, number one. And number two, it not only informs the patient community, but helps the clinical community think about some of these issues. Because, you know, when we're talking to a patient with pancreas cancer, you know, it's a very serious condition. There's no question about that. We're talking about chemo and talking about, you know, very, very significant things from a patient's lifespan point of view. So really, and so there's a tendency maybe to sort of forget the simple things that we can do, relatively simple, that really make an enormous difference to patients' lives. So I think this is really the beginning of what I think will be, as we'll roll out this data collection, we'll find out more about whether it's correct. It's a very early, so I'm not certainly saying it's correct at this point. I'm just saying it's an early look at the data, but certainly we need to get a better feel for that and see whether there are reasons why this isn't happening, and then assuming that it isn't happening as we suspect. So I think that's going to be an important body of work as we move forward, and it will help inform the clinical community as well as webinars like this helping the patient community.
Absolutely agree. That sounds like such a valuable piece of work, and certainly echo what you're seeing in practice too. So look, thank you all for your insights there. I'm actually going to hand back over to David now to open the floor to questions and to give us a bit of a summary of some of those frequently asked questions that are coming through from our audience.
Okay, thank you, Lauren, and thank you, panelists. The information so far has been fascinating, and I'm sure the audience is learning in an incredible amount. Now, we've got about 10 questions. We might not get through all of them, and I think there's some that have appeared in the chat as well as in the Q&A, but as promised, we will answer them all in a follow-up correspondence to all participants. A couple have been answered already in the chat. So the first one I'll go to is from Georgia Moore. Can you comment on the role and the likelihood of requiring of pancreatic enzyme replacement therapy in patients who've had a total gastrectomy?
I guess I can take that. From the guidelines, there was a chapter on, I think, other surgeries, including total gastrectomy. It's like the patients with the Whipples. You change the way the plumbing is with a total gastrectomy, which is usually a Roux-en-Y gastrectomy. So some of these patients may end up needing supplements because of just the fact that, depending on the length of the roux limb, they may have the food may not pass the pancreas at the right time when things get mixed up. So some of the patients may require enzyme supplements, and it's really a trial and error to see if it improves some of their symptoms, but it's often symptom based. Most of those patients aren't given it generically.
I agree, and I think that the stat or the number cited in the literature is somewhere up to about 20% of gastrectomy patients do end up requiring Creon. So certainly should be on the agenda, on the radar if there are any signs of insufficiency.
Thank you, Lauren. Thank you, Dr. Nikfarjam. The next one is, would routine supplementation of vitamin A, D, E, and K be recommended in practice for patients with PEI, or more so guided by pathology results?
I'm happy to take that one. Ideally,
Thanks,
what we want to try and do is avoid the need for supplementation by actually just enhancing the body's ability to absorb those nutrients. So if we prescribe and administer pancreatic enzyme replacement therapy well, it means that our body's able to digest, break down, and absorb fat and the fat-soluble vitamins that go along with it, which means there shouldn't be any need to supplement those nutrients routinely. But certainly it is something that we look out for in our clinical assessments for any signs of deficiency or inadequacy. And certainly biochemical tests can be utilised to help identify if any additional supplements are needed. But gold standard would be to avoid the need for it by making sure that you're actually absorbing it from food naturally.
Thank you, Lauren. The next question is from Tony Ryan, one of our own at Pancare. Is pancreatic enzyme replacement therapy expensive, and is it covered under the PBS and readily available in rural areas? Who would like to take that?
Well, as far as I know, it's available on it is on the PBS, which means that it's a standard prescription for people who are on a pension card. That's I think it's this will be another Albanese moment, but I think it's something like $9 for a script if you're a pensioner, but I may have that not exactly right, but it's of that order, and it's about $40 for a prescription or $35 is the standard script item. What I don't know, and Lauren, sometimes some of these items come in under those costs, but I suspect not for the enzyme replacement therapy, so I'm not 100% sure, but it is on the enzyme Creon is definitely on the PBS.
I guess Christine could answer. Christine,
yes.
What is your experience?
No.
What is your experience with the costing of these? How much are you? Patients do complain sometimes it is expensive. I'm not sure if all of them have got those benefits that you mentioned, John. But what have you found for the cost, Christine, for pancreatic enzymes?
It is on the PBS, and it is, as far as I'm aware, a normal script. I mean, the truth is, my husband buys them. So I don't know, because he's got a pension card, so he gets them like at the normal pension rate, whatever it is. So as far as I'm aware, it's a normal, in inverted commas, prescription, and the cost is normal as well. The only issue sometimes is they don't have it, and I have to wait a little bit to get it. So I never wait till I've run really low before I go in with another script. So make sure I've got a couple of bottles before, and then I'll go in and get some more. but be prepared for them not to have any. But they will get them. I've never had an issue with it not arriving. It will eventually arrive, and it's not any different to the normal tablet cost.
Thanks, Christine. We've probably got time for 2 more before we wrap up and we can get everyone back to their evenings. This is maybe one for both yourself, Lauren, and Christine. Has anyone used jam instead of applesauce? I have done this before as I haven't had access to applesauce. So I imagine that's for mixing the creon.
Certainly if you're having to break open the capsule, jam has some acidity, so that's generally a suitable choice. I do prefer applesauce because it is more acidic. A yogurt would be similar, so a Greek-based yogurt that's also acidic would be a good choice. But if jam's working for you, then that's fine. Stick with it.
Excellent. And the last one.
If I could, David, sorry for interrupting. I just the beauty of having Google while you're on a Zoom call. I just looked up the creon on the PBS, and it is on the PBS, and it's a standard script item. So I'm not sure, Mehrdad, exactly when you say people are complaining. That I'm sure that's correct, but I'm just wondering whether they exceed the quantity or there may be some restrictions that I don't know, but it's certainly on the PBS.
Thank you, John. Okay, last question.
Depends, sorry, I think it depends what it's for, what the actual creon is for. I think it depends on that as well. I think that when it's for pancreatic cancer or that particular issue, I think it's covered, but yeah, it depends what you need it for and what it's prescribed for.
Okay, well, we'll look into that more at our end and provide a comprehensive answer in the follow-up correspondence. The last question I'd like to get to before I'll close is there any contraindications, and this is from Ivania Marlowe, to PERT in pregnancy? I'm not aware of any. I have an antenatal patient with, and I'm going to get this wrong, steatorrhea with subsequent vitamin A deficiency and extreme reluctance for obstetricians to prescribe PERT. Who would like to take that?
I guess I would say that it's, in terms of the product, what it's made from, unless there's some kind of allergies to pork-based products, there wouldn't be any contraindications. It'd be a very safe medication. I wouldn't see that it would have any issues with taking it during pregnancy. Probably detrimental if you don't and you run into those deficiencies that are described.
Yeah, I was going to make the same point. It's derived from the pork pancreas, and I'd be hard to see how it would be a risky drug in pregnancy. And like Mehrdad said, it's really the vitamin deficiencies that may be a greater risk.
I totally agree. And I think the other thing to bear in mind is that the action is very local in the intestinal lumen, and I'm not sure what absorption of the creon is like, but I suspect it's very minimal and actually has its effect in the intestine, and what ends up in the bloodstream, I feel it would be insignificant. It's just my thoughts too.
Okay, so on that note, I'll wind things up. As I said, we will get to the rest of those questions and provide that follow-up for everybody. The recording will be shared on the Pancare Foundation website for everyone to access. We'll review the questions. We'll also send a digital copy of the new PERT guide book for clinicians post the event, and instructions on how to order hard copies for everybody. I'd like to also acknowledge Viatris and their support of Pancare's provision of education for the management of pancreatic cancer patients. And finally, I just want to thank the panel again for an outstanding session. I think we've covered a lot of ground. An exceptional amount of learning has gone on. I mean, I know I've learned a tremendous amount, and I'm sure everyone in the audience has. So thank you again, everyone, for your contributions. And if you wouldn't mind, there'll be a little survey that'll come your way at the end of this. If you could please, take a short couple of minutes to complete that, that'll really help us going forward as Pancare particularly wants to enhance its capacity to provide ongoing healthcare professional education around pancreatic and upper GI cancers. So thank you everyone for your attendance, and we'll see you next time.